Hey, people can see me. That's cool. Or maybe not. Hi, everyone. Thank you very much for joining us today for our Stroke Best Practice and Heart and Stroke webinar. We really appreciate all of you taking the time to join us today. We're very excited to share with you today our Stroke Month report overview. And really, the purpose today is to give you a bit of an introduction to the report. Hopefully, many of you saw it last week or saw some of the media on it. So we'll share that with you, but then we really want to dig into some of the issues that the report highlights. So I'll give you a bit of an overview of the report itself. Our other speakers, Jill Cameron and Heather Purvis, will then really dive into some of the issues for patients and families after they've experienced a stroke and left hospital. And what we're hoping you'll get out of this is really an appreciation for what people go through, a broader understanding of some of the issues, and what, as heart and stroke staff and volunteers and healthcare providers looking after patients every day, that you'll really have more information now that you can bring to your patients, highlight them on what's available for them, and be understanding to where some of the challenges and struggles are. So I'm just going to take a minute to introduce our speakers a little bit more. Many of you know me. I'm the Director of Stroke at the Heart and Stroke Foundation. I'm a nurse by training with a PhD and specialty in health systems performance and quality. I lead the Stroke Best Practices and Stroke Month activities, as well as staff, and work with an amazing stroke team at Heart and Stroke who really covers all of our different departments working together. And so this month particularly has been a phenomenal opportunity to work with many people who are so dedicated. So thank you to all of our staff who contributed to Stroke Month. Our next presenter after me will be Dr. Jill Cameron. Jill is an associate professor and a vice chair for research in occupational science and occupational therapy at University of Toronto. She has held Ministry of grants in research and innovation, and she's a CIHR New Investigator Award. Her primary research is to understand the experience and needs of families who have experienced stroke. And Jill's well versed in this area and really one of our leading Canadian and international experts on this topic. Our next presenter after that is Heather Purvis. Heather is a nurse who works in Manitoba. So thank you, Heather, for joining us from Manitoba. Heather is also a stroke survivor. She's experienced a stroke, and it took Heather nearly 2 years to return to the workforce, and really had a lot of obstacles and barriers which she amazingly and through strength and perseverance overcame. And so Heather's going to be able to share with you some of that perspective today and really bring this home and very personal to our stroke survivors, because of course we really try to have patient-centered care, and we all strive for that regardless of our role at Heart and Stroke or with volunteers. So just a quick overview. I'm going to speak a bit about the report itself. Jill's going to talk about support for the needs of people who have experienced stroke, and then Heather's going to talk about stroke through the eyes of the beholder. So to start with, our stroke report came out last week, and the goal of our report was really to acknowledge that stroke is no longer just a disease of the elderly. Stroke it can happen to people of any age, from newborns and in utero, young adults. We're seeing more and more. That's an increase. That's really been a big pickup in the media, as well as traditionally thought of people over 65, 70. So we're really now having to rethink our paradigm and shift our thinking, not just to design systems and have information and programs designed for people who are no longer working, are okay not to drive, and have a different lifestyle. We really need to start thinking more about people who do want to get back to work, who have young families as well as elderly parents, and have different needs, and we need to start meeting those needs. We also need to look at what supports are not just in the healthcare system, but in the communities, because we really want, as much as possible, to return people to their communities where they can be active participants. And of course, we know that there's a lot of environmental factors that may inhibit our ability to engage in stroke prevention behaviors and healthy lifestyles, and that has to be taken into account in all of our planning and goal setting. Just to give you a brief overview, the number of people overall admitted to hospital with stroke is on the rise, but at the same time, mortality is on the decrease. In other words, we're saving more people who've had a stroke. Our hyperacute systems, our emergency services, we've gotten really good at that front end of stroke care. And the purpose of this report is to emphasize, since more people are being saved, more people are going to be out there who have needs beyond the acute hospital stay. And we really need to start looking at better servicing those needs and meeting them with people. So some of our key messages, because we are saving more people, is according to the Canadian Partnership for Stroke Recovery report last year, more than 400,000 Canadians are living with the effects of stroke. And the scary part is that number is expected to double over the next several years. What we know is everybody, most people need help of some sort or have certain needs during the recovery. And a lot of those needs we've heard from patients aren't being met. And so our goal is to better understand those and look to see how we can be increasing what patients need so that they can have more optimal recoveries, really maximize how much function they get back, and be engaged members of their community and feel like their quality of life is good. So as I've said, we know the number of strokes will almost double in the next 20 years from the CPSR report. What we don't know is whether we're ready for this, and we don't think we are. We know that the boomers are all coming to that age, so that number is going to increase. We know that half of our people with stroke need some help with daily activities, whether that's simple things like helping with grocery shopping or lawn cutting, or more intense things like help with bathing, feeding, safety, mobility around the home. All of those needs have been identified to a size number of patients, but what we've also learned is that access to supports in many communities isn't available at the level needed. We know that from our data, only 16% of all patients discharged from hospital actually get into inpatient rehabilitation, which means that we have 84% of our patients left without those services. And it may not be the appropriate setting for them, but we do have to make sure that we do have something to offer them regardless of where they live in Canada. And that's a big problem with the Canadian geography. When we looked at where patients are going when they're discharged from hospital, we see that, on the good news, these red lines represent the patients going to inpatient rehab. It is increasing, but we have to remember that the number of people surviving and needing these services is also increasing. So even though it's gotten better, we're not there yet. What we see in these lighter green lines is people going home with home current services hasn't really changed. We still don't have those community supports in place to service people when they do go home instead of being admitted to other inpatient beds. And our long-term care is staying fairly steady, which is your yellow bars. One of the big challenges we've identified, Senator Murray Sinclair, who is one of our spokespeople and experienced a stroke in his 50s, he noted in some of his comments how lucky he felt that he was in a big urban center when the stroke occurred. He's been traveling all over Canada, and in many of those rural communities, we don't have the right services, enough services, or expertise, and we have to start being more innovative in getting services to those areas. Interesting, Annie Rochette, who's one of our researchers, a CPSR-funded researcher, said when you broke down those needs, when we said, 60% of people have some sort of needs after stroke, when you broke those down, if you looked at things like walking, dressing independently, the numbers weren't as high, but when you looked at all those things together for one person, it really started to add up in terms of how much they required. Some of the other issues that we see in patients after stroke, we call these the silent symptoms, because you don't see this. It's not like the paralyzed arm or the speech disorder. These are things, post-stroke fatigue, post-stroke depression. These are some of the most important things that really impact recovery, delay recovery, make it harder for people to participate, yet they aren't as recognized and not as diagnosed. So we have to remember about the things we don't see and be sure that we're asking our patients about them. Communication issues is another one of those issues which may not be as obvious if it's not an obvious speech impediment, but there's processing and language issues. We may not see that, but patients really struggle with it, and it leads to isolation. It can lead to depression, and then patients don't recover as well or reach optimal recovery. Another thing we've noticed is the age of onset of stroke is increasing. We know that there's a much bigger increase in people in the younger age groups. In our report, we highlight 3 major categories of ages. So stroke in babies. We know that there's about 10,000 children in Canada right now living with stroke, and about one live birth or term birth every week is a child who's experienced stroke. And that's even higher in premature babies. What we know that rehab programs for kids have really been built around cerebral palsy and not so much directly for stroke. So we need to look at those rehab programs. We need to start enhancing them, ensuring that they are specific for stroke patients, look at the new technologies and the new research, and make sure that we're meeting those needs. As I've mentioned, there's also a growing increase in young adults with stroke. That group is now represents 19% of hospital admissions, which is an 11% increase over a decade ago. We know that in this group, we don't always know the cause of stroke, that a third of them are cryptogenic, which in itself can be very frustrating for somebody with stroke to not know what the actual cause was. But that doesn't mean they can't be making lifestyle changes and doing healthy behaviors to try to reduce their future risk. As I said, they face unique challenges. Many of them want to get their license back. They have young families. They want to be active participants with their children in their programming. And so we have to be really understanding of that and look for programs and services to meet their needs. And then there's our older adult population. We still see 80% of our strokes happening over the age of 60. We know that in later years, those in 85 and above are mostly women because women live slightly longer than men. And we know that atrial fibrillation becomes an issue for women as they get over 80, and that increases the stroke risk. But again, we need to meet their needs. We don't want to automatically have to put a lot of our elderly people into long-term care or supported living if we can find services to help support them at home. They'd much rather be in their home and be more independent, but they need the supports to do that. That's the end of my presentation. I'll now turn it over to Cameron, who will talk to you about supporting patients and families across the continuum of care.
There we go. Elizabeth, you can chime in if I don't have everything up and running. Hopefully you can see me, you can hear me, and you can see my slides. So thank you, Patty, for the introduction, and thank you for the opportunity to speak about the caregiving aspect included in the report. I think, for me, as somebody who's been doing caregiving research for, essentially 20 years, it's wonderful to see how they're continuing to gain in importance, and highlighting them in this report, I think, was an important contribution. So just a few things that I thought we could go through that will highlight aspects of the report, as well as take it a little bit further to sort of highlight some things that I think we could start to do to better support families in the caregiving role post-stroke. So I thought I'd start by helping us, reflect on the important role that family caregivers play, especially across the care continuum. Because stroke is very unique in that it does have that very sudden onset point, and then we can really follow people over time and understand how things are changing and how that might influence their care needs. So we'll look at how their care needs change across the care continuum, and then consider a model of caregiver support and mechanisms for intervention delivery that may try to address some of these needs. So our starting point. So we're really at the point where we recognize that patients, and Patty's already highlighted this, that patients have families that go beyond the medical care post-stroke. So they need to have help managing sort of everyday activities, as well as navigating our complex healthcare system. So let's just say that that's the starting point. We also are now much more aware that these needs are changing across the illness trajectory. So that's some of the things I'm going to highlight today. I also wanted to have a language disclaimer. I use the term caregiver to represent a family member, friend, neighbor, or other individual who provides assistance to someone who is unable to fully care for themselves due to illness. They're not financially compensated for this role at this point in the Canadian healthcare system, but there are many other terms that are used, and I just want to sort of recognize these terms and just sort of say we're all kind of using the same definition, but we're using different terms. So, for example, carer is a term more commonly used in the UK, although I see it starting to creep into the federal government's language as well. Care partner is another term, support network, as well as informal caregiver. So I'm going to use the term caregiver because that's what I'm most comfortable with. So why do we care for caregivers, and why is it important for them to be included in this report? Well, in Canada, we have something wonderful called the General Social Survey, and every few years they ask questions specifically about caregiving in Canada, and we've been able to estimate that 1 in 4 Canadians have been involved in providing care in the community to somebody with a disability. In the context of stroke, we know that caregivers support stroke survivors during their recovery, rehabilitation, and community reintegration as sort of 3 key areas. Hollander and colleagues have been able to estimate that the unpaid labor provided by family caregivers annually saves our healthcare system over $26 billion a year. Now, these numbers are actually out of date because this research was conducted approximately 10 years ago. It would be interesting to see a more recent estimate, but I would suggest it's over $30 billion a year. In the U.S., their equivalent value is over $450 billion a year. And unfortunately, and across illness populations, this doesn't have to be specific to stroke, but many caregivers, because they're stepping into a role that they're unfamiliar with, it can be quite stressful. We speak a lot about the burden of providing care. There can be consequences for caregivers' mental health, their physical health, their quality of life, their general disruption to their everyday life, as well as their work. And ultimately, if you have a caregiver who is not managing well, not doing well, this can ultimately impact the patient outcomes as well. But with all the wonderful things happening in stroke in Canada, we've got best practice recommendations and a lot of wonderful things happening, it's still not standard clinical practice to prepare or support caregivers in this important role. So we, of course, the best practice recommendations came out this past fall, or maybe past spring. Oh my goodness, maybe it was a year ago now. Things are happening quickly. And it's really wonderful for me to sort of reflect on 2 specific modules in the best practice recommendations, one concerning education and the other concerning supporting transitions. And in both of these modules, and we're seeing it in more modules as well, there's recognition of the important roles that families play and the importance of preparing them and educating them and supporting them through transitions. So I think this is a very positive turn in stroke care in Canada, specifically for the caregivers. So what are some of their needs? So again, not being illness specific, if we were to just look at the caregiving literature in general, but also reflecting on stroke, we know they need some kind of key things. One of which is information. Many people don't even know what a stroke is, so it's really hard for them to kind of understand what it is they're dealing with. They also clearly need training in a whole host of different activities, supporting everyday activities for the person who's had the stroke, navigating our very complex healthcare system, communicating with healthcare professionals who often speak another language that is hard for the non-professional to understand. They may also need training in problem solving, so how to manage challenges that come up on a daily type of basis. They also need emotional support, maybe somebody to speak with. They may need counseling, they may need psychotherapy. So these are some of the key things that caregivers are telling us that they need to support them in the caregiving role. Now, if we can look at this in the context of some really wonderful research in the area of social support, Cohen and colleagues, for example, suggest that there are 4 different dimensions of support. I've already spoken about the need for emotional support and to help caregivers manage the emotional challenges they're experiencing. They also need information, which we've talked about. They also need that training in caregiving activities, and then tangible assistance as well. I've spoken with caregivers who have said, in the acute care phase, it's been wonderful that somebody provided them with a blanket since they knew they were planning to stay overnight, or even help them find the cafeteria and get some coffee, or get parking, like very simple things like that. Caregivers appreciate receiving that sort of help. They also appreciate somebody helping them fill out forms that they may need to for some special service that they may be applying for. The other thing, when we look at the support literature and the theoretical work that's been done, this other piece comes up which we don't hear about as much in the literature, and this is idea of appraisal. So caregivers often would like to receive feedback on how they're managing in their caregiving role, and if someone says to them, it looks like you're managing well and that you're doing a good job for the person you're caring for, that can really make caregivers feel better and put their minds at ease in the caregiving role. So these are important things to remember, So whenever I'm doing research and I'm talking about the supports that families need, I talk about all of these different dimensions. The other thing that's, again, we've already mentioned with stroke, is it is very interesting that somebody could be at home living, perfectly healthy on a regular basis in their home environment in the community, have a stroke. It's very sudden onset. Then they go to this massive facility like the Toronto Western Hospital, where they receive very specialized stroke care services. They may then go on to receive inpatient rehab at Toronto Rehab, for example, and then they're more likely to go home. Over half of people who have had a stroke, I think it's about 80%, actually go home ultimately after discharge. But if we think about what a family needs across these different care environments, it could be quite different. So the care continuum perspective is very important, and we suggest that caregivers have needs, and patients as well, that are specific to the stroke event itself, the acute care context, inpatient rehabilitation and outpatient rehabilitation, care received in the community, also possibly institution-based care like a long-term care facility, as well as palliative care. So their needs could be quite specific. What a person receives in the context of palliative care is going to be quite different from what they receive during inpatient rehabilitation. And we just need to reflect on that specifically when we're thinking about family support needs. So in response to these sort of thoughts, it was during my postdoc that I developed with Monique Gignac what we call the Timing It Right framework. And this is a comprehensive 5-phased approach to support families from the hospital to home, and it emphasizes the timing of support needs across the care continuum. And the central premise is that if we can address caregivers' phase-specific needs, we can enhance their preparedness, ease transitions across care environments, and minimize negative outcomes from occurring. So I often have healthcare professionals asking me to recommend a measure of caregiver stress or caregiver burden that they can use to identify caregivers who are in need of intervention. And I've always been hesitant to do something like that because for me, I feel like we can take more of a preventative approach with families. We know that it can be challenging. We know that it can be stressful. So why don't we try to minimize this from occurring? And I think that's what we're really trying to do with the Timing It Right framework approach. So just to highlight the phases quite quickly for you, just briefly, the first 2 phases occur in the acute care environment, the first one being the time around the stroke event itself, and then a period of stabilization after that. And here the goal really is, understanding whether or not this person has had a stroke or not. And once they've had we understand that and we understand the tests that were done, we feel families move into a period of stabilization where they can kind of catch their breath and say, okay, what is a stroke? Now can you tell us more about that? And then the next phase we call the preparation phase, and this is where families are preparing to take a person who's had a stroke home from the either acute care or inpatient rehab. So that what do they need to do to their home or to themselves, to their situation, to help prepare to take this person home in a safe way. The next 2 phases occur in the home environment. The implementation phase, we also call it the figuring it out phase, where families are taking everything they've learned in the context of inpatient care and trying to apply it to their home context and their home environment. After they figure it out, they move on to what we call the adaptation phase, and this is where possibly the person with stroke wants to return to work, or they want to get back to doing activities that are of value to them, and so the caregivers may also have those interests. Maybe they need to return to work as well. But the central idea here is that stroke families have different support needs across these phases. The good news is, as far back as the 2008 version of the guidelines, these ideas were incorporated into the educational component of the best practice recommendation. So I was really happy to see that these ideas really resonated with the clinical population. So now how do you use these ideas to support stroke families across the care continuum? So one possibility is what we call the Timing It Right Stroke Family Support Program. So we first focused on the content of this intervention. We used the framework as this idea of providing either a chapter or a module for each phase of the framework. We continued to consider the different dimensions of social support that I talked about earlier. We did a qualitative study with family caregivers from urban and rural environments, also representing those with aphasia. We also interviewed healthcare professionals, and we asked all of them, and we said, what do families need with respect to support at different points in the illness journey. And then we learned from that and really produced sort of a substantial document that really speaks about what families' needs are and how they change across the care continuum. We were able to leverage existing resources. We had to develop some new materials, but ultimately we had the content of the intervention reviewed by an interdisciplinary committee, and then anytime we take the program to another city, we have it reviewed and revised for local content. So this is really the content of what the intervention should look like. So the next question is, well, how are we going to deliver this across the care continuum? This is just a table of contents just to show you essentially how we've organized this. So it's easy for a family to open to a chapter and say, okay, this is where I am and this is what I should be looking at now. So when we think about how we would deliver the intervention, we also reflected on our qualitative study. And what we heard pretty clearly from the caregivers specifically is that they said they really wanted one person to be the go-to person for their support, to coordinate all of the different information they were receiving and help them make sense of it. They also spoke about the importance of having follow-up after they left the hospital. So that gave us some insight. We then went to the literature to see what others have done. Joan Grant and colleagues have done a lot of work on telephone support, and it seems to be quite effective for family caregivers, because if you think about it, it's really difficult for them to leave somebody in the home environment and go to a support group off-site, for example, or back in the hospital. So the telephone idea may be very feasible and manageable from a family perspective as well. We also looked at how they were doing this. So we saw trained nurses, family support organizers, case management models, but the central idea of all of these different approaches was that there was one person who was trying to coordinate and oversee everything. So what we created was what we call a stroke support person, who was one key individual who met in person with the families during acute care and then by telephone outreach thereafter. So our stroke support person in the context of our research project has typically been in a healthcare, or actually always been a healthcare professional with some level of expertise in stroke management and care. There's been occupational therapists, nurses, social workers. We've had a physiotherapist as well in that role. The question of trained volunteer has come up, and just in recognition of time, I'm not going to speak about that right now, but if somebody asks that question, and I will respond to it in the discussion. So what our stroke support person does, again, they're trying to address all those different elements of support. So they're trying to ask or provide emotional support by asking the caregivers how they're doing. We go through the information content in the guide to see if there are things they'd like to speak about. We try to give them some insight by saying other caregivers have said this was important in the past, would you like to speak about it now? We also give them some tangible assistance and guidance, for example, helping them to navigate appropriate resources. And we always try to provide them with feedback, so appraisal. And so saying things such as, it sounds like you are managing well. The one thing that I did want to highlight is our stroke support person is not trying to replace existing services, but help families understand what these services are and connect to appropriate services to meet their needs. So that's what our stroke support person looks like. So the idea here, again, is trying to give families support they need when they need it. We've tested the intervention in a pilot trial. Our protocol is published as well. We've completed now a multi-center randomized control trial, which was actually funded by the Heart and Stroke Foundation. And I'm just finalizing the data analysis and looking for time to write, and hopefully those papers will be done. In a nutshell, we've been able to suggest that caregivers who need an intervention, who are more in need of support, will benefit from it. But there are caregivers who are going to manage on their own just because of the resources that they have available to them already. So really the take-home message is here, I would say, is that support is multidimensional. It's not just information, it's not just emotional support, it's also training and that appraisal idea. The needs change across the illness trajectory. There are many different ways of meeting their support needs, and the timing it right model is one way to think about it. There can be application to other illness populations, and I've talked about this in some other contexts. And for me, really, timing is the lens. I no longer ask families what they need. I also ask them when it is that they need this. So we can really understand and try to pinpoint when needs are occurring and how to best meet those needs. And I think that is all for me. I'd like to thank everyone, the Heart and Stroke staff, and all of the funding for the research, and the participants as well for support of this work. And now I'm going to pass it over.
Good afternoon, everyone. Let's see if I can do this without making a mess here. Hopefully everyone can see. Good afternoon. My name is Heather Purvis. I'm going to give you a few slides. Not a lot of information on the slides per se, but I'm going to speak a lot to the slides and hopefully give you a sense of where I was, where I came from in terms of my stroke. When I experienced my stroke, I was 33 years old. I was a cardiac cath lab nurse at the time, and it was an awesome job. I loved it. I was also cross-training to be a cardiovascular tech through BCIT at that time. I was a wife. I'd been married for 8 years at that point, and the mother of a 2.5-year-old daughter. I had very supportive parents who had just both retired, my mother retiring as a nurse. I ran an all-women's pipe band. I taught bagpipes, and I was a piping judge. I had my piano teacher's certification and had a few students. My music and my family were my life at that point. I was basically in my prime, and overall, things were pretty good. It was January 3rd, 1999. I awoke at about 6 a.m., and I wasn't initially certain what woke me up, but I soon recognized that I had a very unusual, icy frontal headache. I got to go to the washroom thinking nothing of it at first, but by the time I returned to bed, I had the sensation that the right side of my body was weakening. In a short period of time I knew something was not right. Initially, I was in denial of real good healthcare provider. I was young, and I had no cardiac history, so this couldn't be happening. I thought, I'll just go and lay on the couch for a while. As I laid down in the living room and closed my eyes, it quickly became apparent that there were changes going on in my body that I had never experienced before. For one, my right side was becoming weaker, so I staggered back down the hallway to my bedroom. I let my husband know that I needed medical attention. He groggily dialed 911, and we waited. Many things began to happen that I distinctly recall. My daughter wandered out of her bedroom, wondering what was wrong. The ambulance didn't come on the first call. 10 minutes later, my husband called again. By this time, we'd also called our neighbors so that the wife could entertain my daughter and the husband could watch for the ambulance while my husband cared for me. It finally arrived, and I was transferred in the -30 Celsius January morning to a local hospital. In fact, the hospital that I worked at. All the while, my right side continued to weaken, and soon I couldn't even keep my legs tented in front of me as I lost motor control of my right leg. Things were changing quickly. I'll just skip a slide here. I was transported expeditiously to the hospital, as I mentioned, where I worked. It took 3 days of testing to figure out what was going on. It turns out I had a very small dissection in a congenitally malformed right vertebral artery up the back of my neck, which was healing, but a clot released where it was healing to cause the stroke. In the meantime, I experienced dangerously high blood pressure, an inability to maintain balance, even sitting in bed, and I wasn't able to tolerate bright light. I was really scared, but I tried not to show it. I soon began to wonder, what does this mean for our family now? How am I going to work? How will I look after my daughter? And interestingly enough, will I ever play bagpipes again? A real quality of life issue for me. My odyssey of diagnosis, treatment, and rehabilitation lasted for close to 2 years. Thankfully, there was no surgical intervention needed. My left vertebral artery was much larger than the right one that had dissected and had been compensating all those years for me. My acute care hospital stay was 3 weeks. My inpatient rehab admission was also 3 weeks, and my intense outpatient therapy lasted a further 7 months. The 2017 stroke report released this past week speaks to some of the challenges and fears I had to face in my management and recovery. For one, how would I manage my activities of daily living? At first, just getting through a shower routine was enough to exhaust me for the day. I would also want to tell the physio and occupational therapist to get lost. I was so tired. Didn't they realize how sick I was? I didn't want to walk in the hall or climb stairs or dance around the rehab room as part of my therapy. As a young active person, I often thought what would have been if I'd been elderly and experienced a similar event. Giving up in this scenario often crossed my mind. But every day I would do what they told me, and imperceptible to me, but very apparent to those around me, I slowly began to recover. Transportation challenges were definitely something I hadn't bargained for, and something that stroke survivors don't initially consider. You don't realize as a young person how much you take driving for granted. I had now lost my driver's license. I couldn't even manage, as I'd mentioned before, to sit up, never mind drive anywhere. Anytime I was in a car, for a number of months after my stroke, I was severely nauseated. Now, I had appointments with physiotherapy every other day, regular blood work, doctor's follow-up appointments. How was I going to get there? In addition to transportation, I still also needed personal care of myself and care assistance for my daughter. Thankfully, in my case, as I mentioned, my parents had recently retired in their mid-50s. While my husband had to return to work, they were there to provide the child care and transport whenever I needed while I recovered. Depression was never something that I ever associated with myself. I was always happy, positive, and forward-thinking. Now I found I was short with people, mostly my family, and I couldn't get past the here and now. I was lucky to have a good pharmaceutical plan through my job so that antidepressants could be prescribed and covered. These took the edge off and allowed me to channel my negativity into a calmness that people today comment on in my current job. I knew finances would also be a challenge for our family. My husband had a good job, as did I. However, I'd only been working half-time, enjoying a comfortable work-life balance. I was lucky that I worked at a job that had good health benefits with disability protection. When we had taken out loans in the past, we'd also added disability coverage. So now, these payments were not a stress. However, not every Canadian enjoys this kind of backing. In this 2017 stroke report, we recognize that the service gaps are there. And that's the first step in trying to overcome them. It's a way of opening up the discussion between service providers, community groups, government, and most importantly, patients and families to develop solutions. I was one of the lucky ones, and I recognize that. Some find this statement difficult to understand, but for me, it's true. If I hadn't had this stroke, I would likely not have moved to another part of Canada, which our family did. I lived in Southern Ontario for 7 years, 10 months post-stroke. I then would have not met all of the wonderful people who are now some of my best friends. And I likely would not have even attempted a graduate degree. And additionally, I wouldn't have had the opportunity to play bagpipes in 2 of the top pipe bands in the world located in the Toronto area. Many good things have come from this bad. So as of today, I'm back at about 90% of my pre-stroke capabilities. If you were to look at me, you would not know I had even experienced a stroke. But I know it every day. I sometimes get dizzy, I lose my balance, I have one droopy eye, and drag my right leg a bit so I might trip on occasion. I don't have temperature or pain sensation on the left side of my face, the left side of my body, and the right side of my face. Therefore, everyday tasks such as cooking and checking water temperature must be done with extra care. I can't do a lot of the physical activities that I used to enjoy, although walking and golfing are still on the list. But the good news is I'm otherwise fully independent. I have a very busy job that can be emotionally draining, but is extremely rewarding. I'll admit, if it's been a hard day, you may find me as the blob on the couch until bedtime. I try to live my life to the fullest, and I try to appreciate the fact that I'm contributing to my family, my work, and impacting other people's lives in the most positive way I can. I live for quality of life, not knowing what quantity I will have. My fight and determination back from a very dark place brought me positives to my life. Not many people get a do-over, but I have. And part of that do-over is the privilege to be able to speak with you today. You'll notice that there's a very busy slide attached at the end here, which is a number of the many educational resources available for patients with heart and stroke, as well as their families. Please become familiar with them and share them with your patients and families going forward. I would like to give a big thank you to all of the heart and stroke staff and volunteers across Canada. You play a very large part in the education and support around cardiovascular and neurovascular events in Canada. Thank you for all you do. Thank you very much.
Thank you very much, Heather, and to all of our speakers for a great presentation. We're just going to get into our Q&A now. So if anyone has any questions, please feel free to share them through the chat function, and we will get to those right away. In the meantime, I did receive a comment, Heather, that thank you very much for your talk. It was very moving, and it was received quite well. So thank you for sharing your story with us.
Thank you.
So this question is for Patty. Why is stroke in young adults increasing? Sorry, we can't hear you, Patty.
Great, thank you. That's a great question, and one that piqued a lot of interest in the news over the last week. There's a couple of things going on. First of all, we're seeing high blood pressure, diabetes, and some of those conditions that normally we wouldn't have seen until people in their 50s and 60s, starting to show up in people in their 30s and 40s. So with the shift in risk factors comes the increase in stroke. A lot of this is happening because we live in a very fast-paced, much more competitive, intense business world than we used to. People who are in their 30s and 40s are trying to establish a career, have relationships, deal with families. They don't take time for themselves. There's a lot more takeout food, a lot more pre-made meals readily for you to grab on the way home. You're not getting enough of the fruits and vegetables, and by the time you get home, have dinner, get the kids to bed, get the homework done. You're so tired, you don't have time to actually go out and exercise and do things for yourself. So all of this together becomes a very complex phenomenon, and the end result is we're seeing increased stroke in 30s and 40s.
Great, thank you. Other than the resources we already provide, we have another question here. Other than the resources that are already provided, what plans do we have to provide further resources to stroke survivors and caregivers in the future? Maybe Jill, you can address that one. I think we have quite a few resources. I think really, to be honest, the biggest challenge for families is accessing resources that they don't know about, because there are a lot of things out there. Heart and Stroke has a lot of things, March and Dimes, the Stroke Recovery Network. There are a lot of resources around the country, and it's helping people to link up to them. I think even like the new intervention that I had, it's really more of a navigator kind of role and helping people find things. But that said, the majority of the programs that are available are in large urban centers. So we need to probably figure out how to make more programs and services available in smaller communities and more remote communities. We might be able to partner with other conditions. So we're talking a lot about stroke today. Maybe partner with some of the programs that are there for rehab, for heart disease, for Alzheimer's disease. So expanding in some of the smaller communities to other illness populations might be one of the strategies we could use.
And I'll just jump in as well. We really want to encourage all of our heart and stroke staff and all of our healthcare providers that have joined us today to be aware of what programs are out there. If you go to the Heart and Stroke web pages, we have lots of areas that you can link on yourself so that you become more familiar with these resources. Many of them are free of charge. Your Stroke Journey, which is our significant Life After Stroke guide, everything you needed to know, it is available. We're trying to get it in the hands of everybody who leaves hospital after stroke, and we know that we're not penetrating as much of the country as we want to be. So please reach out to us, reach out to your provincial Heart and Stroke to get these resources. We're happy to share them, and we've had really good feedback from patients that they do add value. So part of putting that slide up was for you to see the array of what we have and to start getting more access and sharing them. And share them with your rural communities that the big hospitals link with as well. Thank you.
And do you have any recommendations for those that, or any thoughts around those that work with aphasic individuals who often become isolated and decline due to lack of therapy and or stimulation?
Bill, do you want to start?
Sure. I think of the Aphasia Institute and the wonderful things they have going on. I think, helping families to recognize the role of a speech-language pathologist, of course, and helping them access programs. I don't know a lot about what aphasia programs are available across the country. I know mostly about what's available in Toronto. So having that as another resource that Heart and Stroke could help people link to would probably be valuable.
And one thing that's happening across the country, so really innovative programs happening right now, where people, and Heather, you may know this, in Winnipeg, there was a speech-language pathologist who was actually using an iPad, and in remote communities, they were supplying iPads to patients after stroke to link with a retiring speech-language pathologist who was doing speech therapy using electronic communication. There's a lot of programs available in our digital age to support communication issues and to help reach more patients. So we really encourage you, again, to become familiar with some of these, link with the Aphasia Institute in Ontario, but other speech-language services in other provinces. Patients who have experienced aphasia are at high risk of becoming isolated to have other complications because of the language. And people often assume that they either have cognitive issues or are depressed, when in fact it's just they're unable to participate in a conversation. So we have to be really sensitive to that and really make an effort to build supportive communication skills and be able to work with these patients.
And the only other thing I will add, just going back to the families as well, so this is part of the training that they would probably benefit from receiving. So helping to train families on how to communicate with people that can't communicate with them. So it's another important part of the training piece that we can't forget about.
For sure.
And just another question. One individual hears from young stroke clients that they hear that they are doing so well, but then are
at the same time, and many say they feel there are not enough resources for them around childcare. So do you have any comments around resources and accessing resources for childcare?
That's not an area we've really looked into, but it's a great point and an important one. Some of the areas we've been looking into is just access for rehab that's affordable, because people who are younger don't have the same benefits. Heather commented that she was lucky she had a great benefit plan for things, but a lot of young people, depending where they are in their employment, don't have access. And childcare is another one of those issues. Not one we've explored in detail, but certainly now that this has come up, that's a great point, and we will look into that further.
It's interesting. If you think about somebody who typically uses childcare, they use it so they can go and make an income. So if they're now not able to fully make that income, and now they want to, how can they afford childcare as well? So it's a challenge, and I agree with Patty. I haven't seen anything in the literature talking specifically about that.
And Patty, you mentioned iPads and so forth. Can you expand at all on how technology may be being leveraged to support patients and caregivers?
For sure. There's been actually quite a bit of research, especially funded by Canadian Partnership with Stroke Recovery a couple of years ago, looking at using telemedicine. So in hyperacute stroke care, telemedicine has become an important component of our stroke system, where patients who are in smaller communities can still have access to clot-busting drugs, TPA, and other therapies. And now we want to take that technology and expand it into rehab. You know, rather than having to be in the room with the exercise therapist, to have exercise being done by joining a remote class and having a leader in one place and participants in many places. So there's been some really neat research both on exercise, on cognitive impairment after stroke, and therapies that have been using different iPad technology or, video conferencing, those modalities. We really need to expand outside of the hyperacute area. Our recent telestroke guidelines, which were published just a few months ago, have started to look at that and explore the evidence in these other areas. And this is a technology age. Almost everyone has some sort of a device, and we need to start using that more. And there's a lot of research right now looking at that.
On the family and caregiver side, somebody just finished her PhD working with me last spring, or she finished last fall, but her name is Marina Bastał-Wesolewski. If you need to connect, I'll help you. But she specifically had an interest in looking at how adult children access peer support for their caregiving role and how they use social media, so Facebook, online interventions, and it was really quite interesting. And what it came down to was that caregivers had an understanding of what they needed, and it really didn't matter whether or not they were meeting with somebody in person or online in some form. They were able to get the supports they needed, irregardless of the modality. It was really interesting.
Great, and we got a couple questions for Heather. One individual says, thanks for sharing your inspirational story. I'd be interested in learning if music played any role in your recovery.
I think it probably did. Again, one of the things that I was always asked to do was go to the auditorium and play the piano. Now, I do play the piano, but I find because of the nystagmus I had post-stroke, I wasn't able to read a line of music. So I found that very frustrating, and I'm not one to play by ear. However, I could pull my practice chanter out from my bagpipes, and I was still able to go at it. So I'm hoping that that was part of sort of the recovery and the ability of the brain to heal itself, because it certainly did in my case. I had a couple of examples, one being I was not able to drive. I had my license back, but I wasn't comfortable to drive because I couldn't turn my head and shoulder check. So for the longest time, I adjusted my ears and my mirrors, and I was very careful on how I drove until such time I was able, practicing a little bit at a time, shoulder checking, and eventually I was able to do that. So, the ability of music to sort of help in the healing of things like this, these brain traumas, I think is extremely important. And I was able, 3 months after my stroke, to be back playing with a top-notch band in Ontario, which was, to me, amazing and yet comforting. I was still able to have this piece of quality for my life.
And another question for you. What did you feel was your greatest resource in your recovery? And in retrospect, what could healthcare providers have done to increase your motivation to engage in rehab and physio?
Maybe they could have put food at the end of the hall. I'm not sure what would have increased my participation. Just because I felt so awful, and I guess a good chunk of it was the post-stroke fatigue that I felt. I just didn't want anything to do with any type of therapy or, as I mentioned, the climbing stairs, the walking the hall, and I went right from, not being able to even stand to using a walker up and down the hall to using a cane. I mean, it did progress gradually, but I'm not sure if there's anything anybody could have done in that regard except, my parents came by and gave me a little kick in the butt to say, let's get going. You've got to do this. So, I mean, it was lots of family that were providing that support. I don't know what happens with someone who doesn't have that resource available to them in terms of family. And knowing how busy healthcare providers are right now, I don't know if there would be somebody, it would have to take a very special person to say, you know what, you need to do this and this and this, come on, you can do it, and give a lot of that encouragement and empathy and everything else that you really do need to get going.
Great, thanks. And I recognize we're at 2 o'clock, so if you need to sign off, feel free to. But I just have one more question that I wanted to direct at Heather. Did you find in general therapy is more directed to physical, visible symptoms versus language, speech, and cognitive ones?
Well, in my case, I didn't have the aphasia, the dysphagia, the problems with, those types of cognitive therapies, and the need for them. I was lucky that way. So all of my treatment was directed towards the physical, be able to get that balance back, be able to deal with the depression, be able to deal with sort of the balance issue. So I really didn't have a lot of that experience. I did, however, have a very unfortunate woman across the room from me who had actually been in a car accident, broke both of her femur bones in the car accident, was recovering, and then through fat emboli from those fractures, and ended up in the same, in a horrific way, who couldn't speak. So I know, trying to help her as the impaired care provider, I couldn't imagine the frustration that somebody like that would go through in trying to, recover and move on. You're really stuck. You really are.
Great, and thank you very much for those responses, and to all our speakers today for great presentations. Lots of Q&A happening, so a lot of great information that you've shared, so thank you so much. I just want to remind everyone that we do have a webinar on June 22nd for patients and caregivers that will talk about transitions into the community and self-management strategies and accessing resources within your community, and we'll send out the link to that webinar so you can share it amongst your networks. And we're pleased to be offering this first webinar to patients and caregivers, and look for more information along with the recording and survey. And again, thank you for your participation, and we hope you enjoyed today's presentation. Thank you very much, and have a great day.
Thanks, everybody.
Thank you.